question then is, especially given the quality of life data, if we find an ESR1 mutation at baseline, do we just start camizestrant? If we find an ESR1 mutation and that has emerged and the patient is asymptomatic and telling us that they're feeling fine and we have no radiographic progression, would you wait and start camizestrant, or would you take the SERENA-6 approach and start camizestrant? Manali, what would you do?
Yeah, I think these are all very good questions. So, the incidence of having an ESR1 mutation at baseline is very low, less than 5%. And so we don't see very many patients that are going to be candidates for an oral SERD from the get-go. I think it is so true what you brought up, that transition after progression on first line can be quite traumatic to the patient, mostly because what we've seen in the second and third line setting is that the time of progression-free survival on next therapy becomes shorter and shorter. And any treatment switch causes anxiety. There's anxiety about not only just the change itself, but what are the new side effects I'm going to be experiencing? How long is my cancer going to respond to the next line of therapy? And so I definitely think that will play into the decision-making on if I have a patient that has an emergence of an ESR1 mutation, regardless of radiographic progression or how they're feeling, if I can tell them this is going to prolong the stability of your cancer on frontline therapy, this is going to improve perhaps how you feel, even though you may not be asymptomatic right now. In the future, as we near progression, you might experience some symptoms. If that can improve how you feel and your quality of life, your ability to work, your ability to interact with your family, extend those things, I think many patients would want to switch early, although it, again, requires a balanced discussion on the pros and cons of that treatment approach.
Absolutely, and just to clarify the baseline question, let's say you have a patient who recurred and is now presenting, first-line treatment, and you pick up an ESR1 mutation. Yeah. Would you start a camizestrant approach for that patient?
Well, currently we don't have the approval of camizestrant. I think we do have 2 oral SERDs that are approved, and I do try to get an oral SERD approved for treatment of that patient with an ESR1 mutation. I think in large part because what we currently have available is an intramuscular fulvestrant injection, which can be painful for patients, requires them to come in monthly for those injections, et cetera. I think where we currently stand with the oral SERDs is I'm more impressed by the combination data in terms of progression-free survival, without too much additive toxicities, at least on some of those combinations, that if I see a patient with an ESR1 mutation, I am more likely to search for a combo strategy for those patients than a single agent, except for those more indolent, bone-only, asymptomatic patients in which I feel they're very endocrine sensitive and can have a nice response to monotherapy oral SERD.
That makes sense, and I think, one of the nice things about the SERENA-6 design is, of course, that CDK4/6 inhibition was continued, right? And I think we all feel a little more comfortable with combinations, except in some of the situations that you outlined.